Hello everyone, I'm Dr. Karishma Chawla. I'm an orthopedic physiotherapist, and today our topic of discussion is sacroiliac joint palpation and assessment. So, why is sacroiliac joint so important? Sacroiliac joint is a joint which is present in the center. So, if there is any disturbance at this area, if there is any disturbance in the pelvic area, there is going to be disturbance above and below it. The muscles above and below it are going to be affected. So that is why it is said that pelvis is the kinetic and kinematic center of the musculoskeletal system. So there was this researcher Vleeming. He has done extensive study uh, on the pelvis, and he has done extensive study on the SI joint. And he says that the body's core stability starts with the pelvis, so that the three levers, the leg, the legs, and the vertebral column can be moved. So it is basically a base for the movement of the joints above and below it. So the pelvis is the anatomical and functional center of the lumbopelvic region. The two movement complexes meet that at the sacrum, the vertebral column, and the pelvis. So here you see that, let me use okay. So you see this is the iliac bone. Okay, this is the iliac portion. Then we have this as our ischial tuberosity. Okay, we have our ischial tuberosity here. Then we have our spines, the PSIS and PIIS. Okay, then on the sacrum, this is the last IVD space. Here is the last space for the IVD. Then these are the facet joints. Then here we see the five fused sacral vertebra S1, S2, S3, S4, S5, and the fifth sacral vertebra is going to fuse generally at the fifth decade of life. Okay, generally in men. In women it can take a longer time. So it is, though that is why after 50 years of age, in men it is not very advisable to provide mobilization over the SI joint also, because there also some osseous um, joints are made and it becomes less mobile. Okay, and then we have our coccyx over here. So there are certain differences that are present between a female and a male pelvis. A male pelvis is less wider and the female pelvis is more wider. Then the male iliac crest is going to be higher as compared to females. Females have a lower iliac crest and a wider iliac crest. Males have a more curved iliac crest and females have a more flattened iliac crest. Okay. Then pelvic the pelvic this area, the pelvic area is going to be smaller in case of males and larger in case of females. The ischial tuberosities are going to be nearer in case of males and farther away in case of females. The pubic arc is going to be more in females and it is going to be less in males. Okay. So these were the main differences between the male and female pelvis. So it is very important to learn about the weight transfer also, how the weight is going to be transferred in different positions. So one corresponds to the standing position. In the standing position, the weight of the body is going to be transferred to the iliac spines. Okay. But when the person is sitting, the weight is going to be taken by the ischial tuberosity. Okay, the tuberosity is going to take the maximum weight. And when the person is moving, at the time of moving, the force is not going to be compressive, but a tensile force is going to be there, and that tensile force is going to be taken by the pubic symphysis. Okay, so weight is going to come on the pubic symphysis during walking. And how much weight are we talking about? It is going to be approximately 60% of the entire weight, which is taken by the SI joint. Now, it is also very important to know the normal position of the SI joint, or the normal position of the sacrum. Okay, so the sacrum is always anteriorly tilted or anteriorly nutated, and that nutation is going to be around 30 degrees in normal population. Okay, so how do we find it? We can find it on an X-ray also. So on an X-ray, we draw a line and extend it on the upper surface, that is going to be oblique, that is the upper surface of the sacrum, and the second line is going to be the horizontal. Okay, and then we see the angle made by a goniometer. Okay, better use a transparent goniometer for this. So in general, it is going to be 30, but if a person has an increased lordosis, in that case it is going to be more than 30, and if a person has flat back, it is going to be less than 30. Then we should understand the basic areas or basic surface anatomy of the sacral bone. For that, we have here, as we know, this is the space for the last IVD. These are the facet joints. Then here, this is your auricular surface. Okay, these are your auricular surface. Then in the middle, we have the median sacral crest. So these crests are palpable, but till S3, from S1 to S3 they are going to be less palpable, and from S3 to S5 they are going to be more palpable, because from S1 to S3 there is going to be more muscle mass and fat mass, but from S3 to um S5 there is going to be less muscle mass, so it becomes more palpable here. And also, the auricular surface are not palpable, but from S3 to S5, the areas, that is the edge of the sacrum and the inferiolateral angle, are going to be very much palpable. How do we find the inferiolateral this edge of the sacrum? Because here we palpate the S1, S2, S3 vertebra, then we go laterally, and the first dip that we feel, the first dip where we find a little bit of resistance of soft tissue and the bony resistance is over, that is where the edge of the sacrum is. Then we follow the edge of the sacrum downwards, we will see a angle being made, sudden change into a medial side, that is where this is our inferiolateral angle. This is also a very important part to be remembered. This is an important part because certain ligaments are going to be attached to these parts. So then, just after the inferiolateral angle, we are going to have a bony projections on both sides. These are the sacral horns. Okay, this is also a very important part. Then, if you come from upwards downwards, so you will find a dip here. You will find a dip, and it is going to be a deep dip. That is what is the sacral hiatus. Okay, this is the sacral hiatus, and this sacral hiatus is going to be having a membrane or a ligament here, which often gets painful when a person falls on the buttock. Okay, so now see the ligaments I was talking about. From the sacral horns and the inferiolateral angle, we are going to have a lateral sacrococcygeal ligaments, and at the sacral hiatus we are going to have a deep posterior sacrococcygeal ligament. These all the ligaments are very much prone to getting overstretched. Okay, if a person falls on the buttock or on the coccyx, these ligaments are going to be really tender, and the first line of treatment for these ligaments are going to be, you are going to provide a sitz bath with ice, or you are going to provide a wet towel, ice dipped wet towel over here. When the inflammation is subsided, a little bit subsided, you can provide a transverse friction massage to um, treat these ligaments. Okay, so nothing else is required, and the ligaments are going to be healed very soon, and the pain will be gone. Then we have certain other ligaments which are more important. So in in general, we divide the ligaments into three parts. So first is the interosseous ligament. Interosseous ligament is present uh, just at the back of the SI joint. Okay, so these ligaments are important to us because these are the ligaments which have a maximum number of nociceptors. Okay, so whenever there is any change in the morphology of the SI joint, if there is any dysfunction at that point, it is going to produce pain into this interosseous ligament. So if you assess a patient and you are assessing the PSIS, and that person is complaining of pain with the palpation, so generally it is this ligament which is at fault, and it is giving you an indication that there is some pathology at the SI joint. Okay, so it is very sensitive to any change in SI joint. Then there are ligaments which are going to restrict nutation, that is anterior sacroiliac ligament, posterior sacroiliac ligament, sacro-tuberous ligament, and sacrospinous ligament. Then we have one ligament which is going to limit counter nutation, that is long posterior sacroiliac ligament. So now you will say that this is not fair, that nutation is having so many friends to restrict. Okay, now and counter nutation is having no restrictions. Why? Why is it so? It is because if you see here on the first diagram, you will see that uh, the line, the axis of rotation, the axis of rotation is this black line. Okay, and this is the line which is the weight bearing line. Okay, so this weight bearing line is basically anterior to the axis of rotation. Okay, uh, because this weight bearing line is anterior to the axis of rotation, the sacrum will have a tendency to nutate anteriorly. Okay, that is why we need more nutation restrictors, because it is always at all times having a tendency to nutate anteriorly because of the weight arm. Okay, so how is it going to work? So if you see, this is our sacro-tuberous ligament, which is coming from the edge of the sacrum and going to attach on the tuberosity. So whenever the sacrum is going forward, it is going to pull it backwards. Okay, so that is how it is not allowing the sacrum to go and nutate forward. Then this is the sacrospinous ligament, which is having more of a compressive force. So now, as this tip tries to go upwards, this sacrospinous ligament is going to provide this force, which is going to have a compressive effect. Okay, it is not going to let the tip go upwards. Then so this is just one ligament here which is going to restrict counter nutation, that is long posterior sacroiliac ligament. How is this going to work? So when this sacrum is coming backwards, it is counter nutating, this is going to have a upward pull, and it is going to make the sacrum go in nutation. Okay, So that is how it is going to restrict the counter nutation. Then there are certain things that you should always remember when analyzing or assessing the sacroiliac joint. First thing to remember is that the sacrum and ilium is always going to move against each other. That is, if the sacrum goes forwards, the ilium will go backwards. Okay, and when the ilium go forwards, the sacrum is going to go backwards. So it is always going to move in opposite directions. Then this movement of the sacrum is always going to happen in a frontotransversal axis. Frontotransversal axis is basically uh, it is between the frontal and transverse axis. So it is going to be oblique axis. So this oblique axis is going to make the sacrum move in a rotational movement. Like one side of the sacral base is going to rotate forwards or go forward, but the other side is struck there, while the corresponding side, the contralateral side of the tip of the sacrum is going backwards. So it is going to be a rotatory movement. Okay, so if this is coming forward, this side is coming forward, and this is the axis, that is right oblique axis, then this is going to go backwards. Okay, and okay, so this is how it is going to be a oblique movement. And there are a lot of you can say thing that people say that there is no movement at this sacrum, or there is no movement at the SI joint, but there are researches which prove that there is 2 to 2.5 degrees of movement present at SI joint, but it is true that these movements are lost at as the age advances, or if the patient has a very tight ligament. Okay, there is very much of tautness in the ligament, so then we won't have our movement. Then ilio-lumbar ligament. So ilio-lumbar ligament is also a very important ligament to know. This ligament often is a cause of pain in patients. So ilio-lumbar ligament, if you see the anatomy, it is coming from the iliac crest and going towards the lumbar transverse face. Okay, so if you see, okay, now if the lordosis is increased, this lumbar vertebra will go forward. Okay, because it goes forwards, it is going to take this ligament with itself because it is attached there, and this will cause a traction force over this ilium. So what will it do? It is going to cause a compressive force over the sacroiliac joint. So if you know the vectors, so this is the ligament. If this is the force vector, okay, if we divide into vectors, one is going to be upwards and a larger force is going to be in this way, and this force is compressive in nature. So that is why whenever a person has increased lordosis, in that case that person is very much prone to develop pain at the SI joint, because the ilio-lumbar ligament is going to cause compression at the SI joint. So these ligaments, you should know about these ligaments, because these are the small things which we miss during our assessment. Okay, so if you know the mechanism, you can assess them properly. Now let's talk about the sacrotuberous ligament. We already know what how sacrotuberous ligament works, but now the sacrotuberous ligament is also very important ligament during the walking. So this research was also done by Vleming. So he said that this sacro-tuberous ligament actually is going to merge with the fibers of biceps femoris. Okay, the fibers of biceps femoris, that is a part of hamstrings, it is going to merge with the fibers of sacro-tuberous ligament. Okay, so what will happen, that this hamstrings is basically responsible for decelerating the knee, okay, in swing phase. So during this, when these fibers are merged, when it is decelerating, it is going to have a force in this direction. So this force is going to cause, it is going to prevent the sacrum to go into too much nutation when in swing phase. Okay, so when in swing phase, basically our ilium is moving backwards, right? So sacrum has to move forwards because it is always moving in an opposite direction, but it should not go too much forwards. So that is prevented by sacrotuberous ligament during the gait also. Then we come to the palpation assessment. So for palpation, basically we have two types of palpations. That there is quick palpation and there is local palpation. Okay, quick palpations are palpations in which we just know this is the surface where we have to palpate and we palpate. And then local palpations are those in which structures are, you have to find the structure. Okay, so that is how the local palpation works. Then there are local palpation in which you will have to project certain lines to find out where the structure is. So those are also local projections. So how should be the starting position? The best starting position is going to be a prone position, and always start your assessment after squaring the pelvis. Okay, so it is going to be a prone position with the arms lying next to the body. Arms should not be above the body, because if it is above the body, it is going to stretch the fascia and it is going to result into false positive results. Okay, so we don't want that. For that, we need our arms to be at the side, and there should be no neck rotation, because neck rotation is also going to cause changes in the fascia. So again, to avoid that, we don't need neck rotation. For that, the plinth with which is having space for the face, uh, that those are the. Then how do we palpate the iliac crest? Iliac crest is very easy. You just place your hands like this with the thumb abducted like this, and you see, what you have to see is, you have to see the level of the iliac crest. If one is up, one is down, maybe there is upslip on that side. You can see which is more palpable, which is less palpable. If this side is more palpable, maybe it is posteriorly rotated. So these are the things that you have to see. Then this this position, so it is going to be at the L3 L4 level in most cases. Then the next thing that you have to see is, you have to palpate the last vertebra, and you have to palpate the iliac crest. Okay, after palpating both the things, you have to measure the distance between these. Okay, so and you have to compare the distance between both the sides. For example, if this side has more distance, okay, this side is longer and this side is shorter, maybe the quadratus lumborum on this side is tight and it has pulled the iliac crest upwards. So this is how you can assess it directly. Then on the supine position, you can assess the position of the ASIS, and you can also measure, like for example, if he is in supine position and this is the umbilicus, you and this is the ASIS, you can measure the distance between the umbilicus and the ASIS on both the sides and compare the distance. If one is more than the other, that means this side of the pelvis is an out flare. Okay, so That is how you know about the outfloor and inferior also. Then we palpate the greater trochanter. So greater trochanter is basically found at the, if you palpate the tip of the sacrum and then you go just on that line. So here is where your greater trochanter is going to be, just at that line. Okay, so you find the head of the greater trochanter, and if you're not able to find it properly, if the patient has a lot of muscle mass or fat mass, then at that time you can ask the patient to flex the knee and you can do a external internal rotation. With that you will feel the greater trochanter moving, and you will be able to palpate it. Then for the sacrum, you can palpate, as you know, you can palpate the sacrum. Okay, as you palpate the sacrum, you can just go, if you see that, okay, you have palpated the iliac crest, it is at L3 L4 level, then you go downwards, it is going to be L5, then you go downwards, it is going to be S1, S2, S3, S4. You are basically on the sacrum. So as you pass the S3, just go laterally. As you go laterally, you are going to find a dip. Okay, so this dip is going to be the edge of the sacrum. Palpate the edge of the sacrum, draw a line there, and then you will and go inferiorly, and you're going to find an angle made, which is going to be in the inferior medial direction. So this is the inferior lateral angle. Okay, this is the inferior lateral angle. Then as you reach the inferior lateral angle, you are going to palpate the again a bony structure, which are going to be the sacral horns. Then if you come down the S3 level, after the S5 level, you are going to have your sacral hiatus. You should see for the tenderness on the just below the sacral horns. Also, you should see the tenderness. Okay. So this is these are the main palpatory structures on the sacrum. Then then another bony structure is there, that is the ischial tuberosity. You're going to find the ischial tuberosity when you palpate the gluteal crest. So palpate the gluteal crest, go medially. As you go medially, you're going to find a bony projection. That bony projection is your ischial tuberosity. This is important because this is where a lot of ligaments like sacro-tuberous ligament and the tendon of hamstring is going to attach. Okay. Then gluteus maximus. How are you going to find gluteus maximus? You just have to ask the patient to extend the leg, and you have to provide the resistance. But in some cases, the gluteus maximus is not very much appreciable. So in those cases, you can ask the patient to turn the foot outwards and the heel inwards at during the leg elevation. Okay, and then you provide the resistance. If still you are not able to palpate, then just resist the adduction movement with the extension movement. So basically, this can also be used to train the muscle. This is how the muscle is going to be activated the maximum, which is seen in EMG studies. So this is how you can efficiently train the gluteus maximus muscles also. Then we have gluteus medius muscle. Gluteus medius muscle is going to be present between your iliac crest and the GT. Between this, if you palpate and you reinforce your hand with the other hand, you are going to palpate the gluteus medius as the person abducts. Then for the gluteus minimus, how you going to palpate the gluteus minimus? Basically, it is not palpable. The fibers of the gluteus minimus is not palpable because it is covered under the gluteus medius and maximus. Then I want to ask you, is PSIS at the dimples? Just answer me in the comment section. I'm giving you 5 seconds. Please answer. Okay. How do we palpate it? You just have to go to the iliac crest and come medially and follow the indentation, and you will feel a projection at the end, that is your PSIS. And as the projection ends, you are going to feel a dip, and where you feel this dip, there is going to be a flat structure, and that flat structure is going to be sacrum. Okay, so how do you palpate the sacral vertebrae and the corresponding structures? So as you know, if you join the line between the PSIs, now you know where the PSIS is going to be. It is not going to be at the dimple. Okay. So now when you join the actual location of the PSIS, that is where your S2 is going to be. So from S2, you can palpate your S1, S3, S4, S5. Okay. So you palpate till S5. Then after S5, you're going to have a dip. That is your sacral hiatus. You go laterally, you're going to find your sacral horn. Here, this is the sacral hiatus. Okay, your sacral horns are going to be here. So you have already palpated. And if you come upwards, you're going to have your inferiolateral angle. So now, how this multifidus muscle. So, multifidus muscle is a very important muscle for the whole spine. Okay, it is got for the whole spine. How do you palpate it here? So, at the level of S3, at the level of S3, if you place your finger just lateral to the medial sacral edges and ask the patient to do increase the lumbar lordosis or do an extension here, you will be able to palpate the belly of the multifidus. Okay, so here, that is how you will test the activation of the multifidus, and you can see if it is activating correctly or not by asking the patient to uh, raise the leg on the contralateral side. When the contralateral leg is being extended, the multifidus on this side is going to be activated. When the leg on this side is going to be elevated, the multifidus on the opposite side is going to be activated. Then inferiolateral angles, uh, you can find them by placing one finger on the sacral hiatus and the other two fingers around 1 centimeter apart, and that is where your inferior lateral angles are going to be. These are very important angles. Please remember these. So there is another way by following the lateral edge. You can follow the lateral edge, come inferiorly and find this inferior lateral angle. That is also one way of doing it. Then sacro-tuberous ligament. So many a times you are going to have uh, patients complaining of pain over the buttock. You're going, maybe you might think that it is coming from the back and it is the dermatome which is causing this pain, and sometimes you might feel it is the gluteus maximus which is paining. You strengthen the gluteus maximus, you do everything, but the pain is not going. Okay, the pain is not going because particularly locally this ligament is at fault. Okay, this ligament is at fault because maybe because there is a lot of nutation force. The lumbar lordosis are increased, and because of that fatigue it has developed the sprain. Okay, so in these cases, you have to assess this by palpation. How do you assess it? Now we know that sacro-tuberous ligament is going to be from coming from the sacral edges. You know where the sacral edge is now. You know how to palpate it. You know how to palpate the ischial tuberosity. So just draw a line from there to there and palpate in between. Okay, palpate in between, and you're going to have a local tenderness over here. Do some eyes massage and transverse friction, and that is all. Then again another ligament is there, that is the long posterior sacroiliac ligament. So you will have patients which are going to complain that we have pain at the SI joint. You find that there is local tenderness just below the PSIS. This is the ligament which is at fault. It will be found just below the PSIS only, and it is going to be very tender. So just release this tendon again with the transverse friction massage and ice pack, and that is all. Then projected palpations. So certain structures are there which cannot be palpated, or it needs certain projections to be made, guiding lines to be made for them to be palpated. Okay, so this is the first line. This is the basis of the projected palpation, that you have to draw a line from the PSIS to the sacral horns. We know where the sacral horns are, we know where the PSIS is. Now draw a line from the PSIS to the sacral horns, and then we divide this line into half, and from that we draw a right angle line at right angle which is 2 centimeter in length, and just above this line we are going to find our PIIS. Okay, here is where your PIIS is going to be, and just lateral to this we are going to find your SI joint. Okay, then piriformis, this is a very important muscle to be palpated. So it is going to be there. So first line we have already drawn. We have to draw a second line which is going to be from the PSIS to the GT. Okay, to the GT. From the PSIS to the GT, this is the second line. That we draw a third line. This third line is going to be from the, okay, so if we draw this line and we have to divide this line into three parts, three equal parts. So the second equal part, from if we come from the PSI, is the second equal part. There, from there we have to draw a line to the GT. So this is our third line, and between these, so this is a triangle made. So this triangle is basically your piriformis. This is where you will find your piriformis muscle, which is going to be problematic in a lot of problems, like if you are having a tight piriformis, maybe your sciatic nerve can get uh, entrapped there, or you can have pain at the SI joint. So piriformis is a very important muscle to be palpated, and piriformis also tends to have tender points. You have to release those tender points. Then sciatic nerve, you have to know the course of the sciatic nerve, right? So what is the course of the sciatic nerve? The same line, now divide these lines also into three equal parts. At the second equal part, if we come from the GT, this is where the sciatic nerve is going to pass from the piriformis. Then it is going to go to the second equal part of the second line also. From here it is going to pass, and in the thigh, how it is going to be there? You again draw a line from the ischial tuberosity to the GT and divide that line into half. Now you divide this line into half, and where this half is, from here the our sciatic nerve is going to pass. So this is going to be the course of the sciatic nerve. Okay. Then, to know, now we know all the structures that we have to palpate. Now it is very important to know the malalignments that could be there. Okay, how it is going to cause problem. So For that, it is important to understand the sling systems. So we have certain sling systems. Sling system are basically muscles which are connected through fascias. Okay, so if there is going to be any disturbance in one muscle, it is going to cause disturbance in the other muscle. So the first sling system is the superficial, posterior, oblique, and longitudinal sling. This is from the latissimus dorsi, one side latissimus dorsi, and it is connected to the opposite side gluteus maximus and the same side of ITB. Okay, just side, the side of the gluteus maximus and that side only of the ITB. So it is connected through the thoracolumbar fascia. If there is problem, if there is any change, if there is tightness at the latissimus dorsi, it is going to have it is going to tighten the gluteus maximus on this the contralateral side and ITB. So the deep posterior, oblique, and longitudinal sling, it consists of erector spinae of one side, iliocostalis on the contralateral side, and sacro-tuberous ligament and biceps femoris on that side. So if there is disturbance in the sacro-tuberous ligament, it is going to disturb your erector spinae of the contralateral side also. Okay, so that is how they are connected, and they are connected by deep thoracolumbar fascia. Then we have anterior oblique and longitudinal sling. It is connected by external oblique of one side, connected to the internal oblique of the other side. Then, uh, then we have adductors of the same side. Okay. So this is how your sling works, and it is connected by the anterior abdominal fascia. Then the lateral longitudinal and oblique sling. It is made by the quadratus lumborum of one side, same side gluteus maximus, medius, and tensor fasciae latae, and the opposite side adductors. This is how the lateral longitudinal and oblique sling is made of. Okay. So, what are the malalignments that could be there at the SI joint? So, these we can divide into those causing functional LD and those who are not causing functional LD. So, functional LLD can be caused. LLD is limb length discrepancy, that is, difference in the length of the limb. These can be caused by upslip of one pelvis or the rotation malalignment, that is, anterior or posterior rotation malalignment of the pelvis. Then, those who are not going to cause LLD, that is your outflare and inflare. These could be together. These malalignments could be together, but generally, if outflare and inflare is present as in isolation, it is not going to cause LLD. Okay. So functional LLD. Functional LLD is one where the LLD is being caused by tightness in muscle or the soft tissues. Okay. It is not caused by changes in the bony matter. Okay. It is not going to be there because of shortened bone on one side, like that. Okay, so true LLD. For true LLD, how do we measure true LLD? We measure true LLD by measuring the distance between the ASIS to the medial malleus. Okay, so this is how we measure the true LLD, the basic, in the basic form. Then, if we want to know, if we see that there is LLD, okay, so I see that there is LLD, I want to know that this true LLD is because of which structure. So I can see that by asking the patient to lie supine and then flexing the hip and knee of that patient and then comparing the knee. Okay, if one knee is above the other in a hip and knee flex position, that means that side femur is longer. The one which is above that side femur is longer. So there is difference in the femoral length. Then if we don't find any difference in the femoral length, okay, now we want to see if there is any difference in the tibial length. We ask the patient to lie prone and then we see the difference in the your plantar aspect. Okay, plantar aspect. If one plantar aspect is above the other, then we see that we can say that there is difference in the length of the tibia. The one which is above is going to have a longer tibia. So there is difference in the tibial length. Okay. So here we know that which structure is involved, and we can see it in always measure the structures, like if you are assessing the PSIS, that what is the position of the PSIS, always measure with sitting and standing both positions, because in sitting the sacrum is the SI joint is stabilized. In that it should not be above or below. If it is above and below even in sitting position, it is because of a true pathology and not an apparent pathology. Then apparent leg length discrepancy is going to be measured from the umbilicus to the medial malleus. Okay. And if there is apparent limb length discrepancy, you can know that if it is a rotational instability. Okay, that you can know by supine long sitting test. You just ask the patient to lie in a supine position. You see the difference between the medial malleus of both the foot. If one medial malleus is lower, then you ask the patient to sit up, and as the patient sit up, if that medial malleus goes backwards, that foot goes backwards, that means that side pelvis was initially anteriorly rotated and now it has come to its original position. Okay, but in case if the malleus was backwards, okay, in one leg it was backwards, and then when you make the patient sit, at that time that malleus come forwards, that means that side pelvis was initially posteriorly rotated and it has corrected itself. Okay, that is how you know about the rotational instability, whether it was anterior rotational instability or posterior rotational instability. Then for the assessment, you have to know the PSIS position. You palpate the PSIS and you see for the position whether one is up or down. When what is the PSIS position? You have to see. Then you have to see the sulcus depth. At the PSIS position only, you have to see whether one PSIS is more protruded or not. If it is more protruded, maybe that PSIS is posteriorly rotated. Okay, that is how you know about the rotation deficiency discrepancy. Then you should know about the ASIS position. You mark the ASIS and see the position. If one ASIS is upwards or downwards, maybe there is a rotational instability or there is an upslip. So once i- if a patient is having, maybe let's see, this patient is having this ASIS downwards and PSIS on one side upwards, that means it has a anterior rotation. Okay, a patient is having ASIS up on one side and PSIS lower on one side, that means the patient is having posterior rotation instability. Now you see that the PSIS and ASIS on one side is up, on one side. Okay, it is up, and on the other side it is down, that means it is a upslip uh, discrepancy. Okay, this is how you know about the malalignment. Then you should know about the pelvic inclination angle, that I'll explain. Then you have to measure for the outflare and inflare by measuring the difference between the umbilicus and ASIS. That is, if this is the ASIS, this is your umbilicus, this is your ASIS. So you see that this distance is less. That means either this is an inflare and this is an outflare. So this is how you will know about it. Then you have to do a Gillette test, forward bending test, and prone instability test. For pelvic inclination angle, you have to draw a line from the ASIS to the PSIS. That is going to be an oblique line, and then you have to draw a horizontal line. This is going to make a angle. This angle is generally 12 degrees if it is More than this, that means the pelvis is anteriorly rotated. Okay, if it is more, and if it is less, that means the pelvis is posteriorly rotated. Then you have to do the Gillette test. Gillette test is done when the therapist is going to place one thumb over the S2 vertebra and the other thumb over the PSIS, over the PSIS, not the dimple, okay? Over the PSIS, and ask the patient to do hip and knee flexion or the marching motion. And you have to see that when the person flexes the hip and knee, this side PSIS should go downwards, okay? If it is not going downwards and it is stuck there, that means there is hypomobility, okay? So this is how you will know about the hypomobility. Then forward bending test. In forward bending test, both the thumbs are going to be on the PSIS, and then you ask the patient to bend forward. And when the person bends forward, the PSIS should come backwards. Okay, it should come backwards. Why? Because as the person flexes, the sacrum is going to follow the lumbar vertebrae. Okay, so it is going to go into nutation. So as it goes into nutation, iliac crest goes opposite the sacrum. It is always going to move opposite. So iliac, this PSIS is going to come downwards. Okay, so if it is not coming downwards or it is moving upwards, okay, it is moving upwards. That means it is going with the sacrum. It is not following the basic rule. That means there is hypomobility. Okay, then there is prone instability test. So, in this, first, in this position, when the foot is supported, you provide certain mobilizing force over the sacrum. Okay, when you provide this mobilizing force over the sacrum should have certain mobility. Okay, but as the person raises this leg, this mobility should not be there. Now if you do the sacral movement, it should not be there. Okay, but if it is there even after raising the uh, leg, that means there is hypermobility. Okay, it is unstable and it is having hypermobility. And even in this position, when the leg is supported, if the sacrum is not able to move, that means there is hypomobility. Okay, then for the pain, we have Faber, Gangelin's test, open book, and prone gap. Faber, we all know. I'm not going to explain that. That is a very common test. Okay, for Gangelin's, you have to do a hip and knee flexion on one side, maximum hip and knee flexion, and provide a downward force over this leg which is hanging on the side of the bed. So, in this, the patient is going to experience pain over the SI joint, just over the SI joint. Okay, then open book test. In this, your arms in a crossed pattern, elbow straight, and you have to provide a, a downward force over the iliac crest, and it is going to cause a compressive force over the SI joint. Okay, it is, the force is going to come like this, and it is going to cause a compressive force over the SI joint, and this compression is going to cause pain. So if it is, the patient is complaining of pain, that means there is some path. Okay, so before commencing this, I want to tell you that there are certain other manual therapy assessments that you can do for the mobility of the sacrum and the ilium that are well explained by Dr. Capri, and I didn't cover in this. You can just see his video, which they have explained it very nicely. The manual therapy assessment of SI joint, so you can just see there. Okay, thank you so much for listening.